Welcome to our JHM Wiki Virtual Toolkit series, where our goal is to engage and amplify. My partner in crime, Martina Stellaforte Smith, is here. The goal is to talk and then drop questions in the chat, and we'll hopefully be as interactive as we can. So I'm Allison Algo, I'm professor of adult and pediatric infectious diseases here at Johns Hopkins. But in this role, one of my coveted roles, I am the director of our JHM Wiki Collaborative for HIV excellence across Maryland, or Central Maryland. We're five distinguished programs that you can see here, including University of Maryland, Sinai ourselves, across adult, pediatrics, et cetera, and OB, providing care to these populations. And the vision is to achieve a more coordinated response to HIV by establishing mutually beneficial relationships and sharing what we know to enhance how we care for these populations, building on the structures that we have. Today's our signature sharing series, which is the Toolkit series, and our goal is to engage and amplify. So you see something, you share something, you say something. So if you too have something you want to share, please let us know. We'd like to amplify you as well, because there are experts everywhere. But today, so excited, my team was so excited to have Bryan Kutner here to talk to us about, and I'll let him say his title because I think it's so great. There are butts everywhere, but understanding anal pleasure and health for the HIV workforce. A little bit about Bryan. He's a clinical psychologist and behavioral health researcher focused on implementation science. His work aims to improve HIV services by enabling healthcare workers and systems to address stigma and other barriers to care. He specializes in motivational interviewing, which he often incorporates into research studies to enhance patient engagement and outcomes. And again, our team saw him speak at USCHA. I don't know if some of the members of our team are on. I think Yang was on, who came back and said, he's amazing and we have to have him. And there's no way to address stigma, but to just bring it in the room and to then dismantle it. Anybody want to say anything about why you're so excited and share with the team why Bryan had to be here today before we turn it over to him?
Yeah, my name is Yang. We've been in contact for a bit before, but yeah, I mean, it's a bummer to not have Bryan in person. I think Bryan has such a great charismatic personality, and just the research and kind of the move towards transitioning research into practice has been very comforting to me. And so I'm excited to have Bryan join us today and talk about his research and kind of what he's been up to since last year in the conference.
Awesome. All right. So with that, we will turn it over to Bryan. Take it away.
Thank you for that introduction, Allison, and for your words, Yang. Also, that's a very warm welcome. It makes me feel really happy to be here. I'm going to be sharing with you a little tiny bit of the research, but really most of the content of what we studied. And if you ever want to hear about the research itself, we can always share that at some point in the future. So you can see my slides, yes? It
Yes,
says understanding anal pleasure and health.
Yeah.
yes.
Yep. Awesome. Okay. And one thing I want to point out is that there's a website. You're welcome to go to that website now if you want to and just peek around, but you'll have that website at the end of this talk. So everything that I cover, there's a webinar that is kind of this very similar to this content that I'm covering that's on the website, as well as a bunch of resources. But what I want to do is make sure it's very interactive today with you all. So I'm going to walk you through the agenda for today. The first part is the why, the kind of science behind why even talk about this topic of anal pleasure and health. And then the next bit we'll get into is the what, answers to frequently asked questions that you might have or that people you know might have. And then there's the how, and that's all about the resources, which are all housed on our website. And we're going to continue to try to improve that website so that you've got more resources in the future. So there are a couple of guiding mantras before we get into this. So these hold true for how we talk about anal pleasure and health today together, but they also hold true for anyone who's actually engaging in anal play. So the first one is slow and steady. So I'm not going to just sort of show you a bunch of images that might be provocative or shocking. You might be coming in here feeling very comfortable with this topic. You might also be coming in thinking, oh, I don't really know anything about it, and I'm a little bit uncomfortable, and I want to meet everyone where they're at. So we're going to go slow and steady. The next one is ouch. Okay, so if I say anything that lands in a way that causes you pain, I would really appreciate it if you raise that aloud to me in some way so that I can course correct. That holds true for, again, how we talk about anal pleasure and health together, or how you might talk about it with peers, colleagues, friends, sexual partners, clients. It also holds true during anal sex. If there's ever any sort of sign of pain, that is a signal to stop and then course correct to lessen that pain. Or actually completely eliminate it because there's no need to have any pain whatsoever during anal sex. And the last one is have fun. We're going to have fun, and also anal pleasure and health is about having fun. Okay, here's what I'm hoping you come away with today. So the first is that you understand the scientific rationale for addressing pleasure and health, anal pleasure and health in HIV service settings. The next is learning ways to communicate with patients and specifically about physiology and sexual responses in a way that is sex positive, accurate, and destigmatizing. I'm not going to focus so much on the skills because this 90 minutes that we have together is really about making sure that you have a basis of knowledge. And we have a longer workshop where we really focus on skills more, but that's a 2-day in-person workshop. So we can't assume that you'll be able to leave here with the skill set that people got from that workshop. But I'm going to do my best to model how we communicate about it. And you can certainly take that away with you. And then the last one, again, is to gain access to resources to further your education. And that includes a website that's patient-facing, as well as the website is also provider-facing to offer resources. Okay, now we're going to get into what you want to know. So I would love if you would scan this QR code. And then, you know what, I realized I probably should have put that in the chat. I wonder if anyone, if you have the UR code, I don't want to move my screen, but if you have the UR code, feel free to put that in the chat and then you can just click on it if you don't happen to have your phone. And I see this responses are coming. It should be showing them. So I'm just going to refresh this. All right. It says, oh, 1 of 16 responded. Okay, I see you're typing things. I get it. You're also welcome to just unmute or throw into the chat any questions that you have about anything related to anal pleasure and health. And the goal here is that I want to make sure that you actually have a response to some of these questions. All right, they're coming in and you can see them as well. Is butt fun actually fun? That's a good question. Can you have anal sex if you suffer from hemorrhoids? What are non-judgmental ways to ask about anal health as a provider? How to stay healthy, proper lubrication, how safe is anal sex? And there's some more things coming in too. What's normal to feel? How is it possible that anal sex doesn't hurt? There's no such thing as enough lubricant when it comes to anal sex. So here's someone already giving some advice, which is terrific. It's accurate advice too. How to properly clean before anal sex, what's normal to feel, tools and sexual health items to recommend for clients. Okay, excellent questions. I'm just going to ask you now to think about why is it that people have so many questions when it comes to the topic of anal pleasure and health? Why would that be that people harbor so many questions? You see all of them here. And I'm happy for it to be interactive. Like you can unmute and just answer, like respond. So I wonder if anyone is feeling compelled to respond to that.
I can start. I feel like there's not a lot of research about anal health when it comes to pleasurable sex. And so I think that's for me one of the things where, what is the research around healthy anal sex?
Yes. We have been talking about anal sex in the public health field at least since 1981. So 45 years since the beginning of the HIV epidemic that we know has been transmitted predominantly during anal sex. Yet, somehow, we don't know how to talk about it or have basic answers to questions about it. So it suggests that there's some stigma around this topic. And I may not get to every single answer that you have for to your questions today, but I will have a resource for you to be able to get answers to your questions. And many of the things that you've raised, I'll be able to answer because many people have asked them over time. And I see in the chat, people are also saying it's hardly talked about and other things that are related to stigma. Okay. All right. All right. I'm going to get into a little bit of the why this topic, how I got into this. So this is an image of someone who's at a bathhouse and advertising going to a bathhouse. If you don't know what a bathhouse is, it's a public sex venue. It's a place where, at least historically in this case, this was a cisgender man going to a bathhouse to go have sex with other men. And when I first moved to New York City, I worked in a bathhouse, and my job was to sit and counsel and test people as they tested for HIV and other STIs. And one of the things that kept happening is that there'd be a man across from me, usually in his 50s, who would say something very offhanded like, you know, I bleed when I have anal sex, but that's normal, right? Almost like he was sort of throwing away the question, but clearly had the question. And it occurred to me, how is it that this is someone who knows to test for HIV and STIs, has been having anal sex for maybe even decades, but somehow hasn't gotten the message that if he's bleeding during anal sex, that's something he should get checked out? How is it that that's happening? It kept happening repeatedly. Around the same time, a friend of mine went to the gynecologist. This is an image of Bette Midler, who got her singing career start in bathhouses. So that's why she's here. And she's a stand-in for my friend. My friend had gone to the gynecologist, was in the stirrups, very vulnerable position, if anyone's been in the stirrups before, being examined. Gynecologist was just about finished. And my friend said, oh, could you take a look? There's a little something I felt a little bit lower. Gynecologist looked and said, that's a wart. That's an anal wart. Have you been having anal sex? Are you married? And then proceeded to burn off the wart in a very painful way. My friend was then calling me, walking down the street, very distraught, emotionally, obviously distraught, and also physically uncomfortable from the procedure. And it occurred to me, okay, patients, clients, consumers of services are lacking basic information. And then also providers who are delivering services are lacking some basic skills around how to communicate about this. So at the time, I had worked for the Harm Reduction Coalition in California and then New York City, and helping them start a training institute. So I just decided I'm going to create a training about this. So I created a training. I called it Smarter Sex, Anal Pleasure and Health 101. And then lots of people came to it in New York City. But then I decided to go back to school. When I went back to school, I thought, I want to study this in some way. So I'm going to walk you through a little bit of that arc, just so you have some context from about where I come from. So this is kind of, supposed to be a little joke, like what stigma got to do with the little Tina Turner reference. But at first, I was not interested in stigma. I was interested in making sure that providers and clients knew how to talk about pleasure, because from my perspective, that was what was important. But as a researcher, I needed to see if there was some kind of public health significance to this. And stigma is where I ended up landing. So I ended up doing some doctoral work, some studies, trying to understand if stigma toward anal sex actually had any public health significance, if I could quantify it in some way. So I did a bunch of interviews with people around the country, people who are consumers of services, people who are deliverers of services, people who were sex workers, people who were human rights advocates, just to ask them about stigma and whether it was really relevant when it came to anal sex. We then developed a measure of stigma, and then we tested that and validated it, and then we modeled it to see if it had some significance. And here's what we found. This is the simple version of this. People who said that they were high on experienced stigma or anticipating experiencing stigma in the future or internalizing stigma around anal sex were less likely to engage in HIV prevention, in both biomedical and behavioral HIV prevention. That is, less likely to be on PrEP, less likely to adhere to PrEP, less likely to be on ARTs, less likely to adhere to ARTs, less likely to talk to anyone, have talked to anyone about HIV or STI prevention, basically everything we could think of. That was mediated by their comfort. So basically, if people were saying they're endorsing, I've experienced or anticipate or internalized a lot of stigma, I'm less comfortable talking to a provider about anal sex, and I'm less likely to engage in HIV prevention. Here's what one of the participants shared with us. This is a provider. He said, I think patients know that the majority of healthcare providers don't want to deal with their bottoms. I have so many providers that will send their patients to me just for a rectal exam or to do a swab. Anal swab takes 30 seconds. They don't want to do it. They don't want to go near it. And so it creates a kind of baseline stigma there. Oh God, nobody wants to deal with my, you know. You associate it with poop and smelling and farts and all the above. And then if you get a sense that your primary care provider or somebody else doesn't want to deal with it, it makes you feel like there's something wrong with that. Now, one of the things that we learned in the course of this research, this is the statistical model. So if you're not into statistical models, don't worry, just pay attention to the colors. And it's the same basic model that I showed you before. The thing I want to bring up on this slide is that there's a role for social support. We asked people if they had emotional and informational social support related to anal sex. Basically, is there someone you can talk to about anal sex? Is there someone when you have questions who can answer those questions? Do you have sources of information that you feel like are reliable and helpful? And what we found is that people who said who had that specifically about anal sex, they said less stigma for me, more comfort talking with a healthcare provider, and more engagement in HIV prevention. So that got us thinking, it's nice that we're able to say this has some public health significance, but this pink points us in the direction of what can we do about it? How can we offer people some informational and emotional support so that they're more comfortable talking about this with their healthcare providers? So it kind of supported the idea behind that workshop that I mentioned before. I think I'm going to give you a little bird's eye view of this research, but I'm not going to dive into it too much. This is just a little bit of the background. I mentioned this before that nearly all HIV has been attributed in some way to anal sex. This is not me trying to stigmatize anal sex. This is just what we know. And what I want to point out is that it's nearly all HIV among men and about 28 to 40% of HIV among women is attributable to acquisition during anal sex. Now, the one about men is based on epi, and this one about women is based on modeling. But it suggests that there's a larger role for anal sex during a larger role of heterosexual anal sex in HIV acquisition than people have thought in the past. Another thing is that clients aren't comfortable talking about anal health, even talking about like hemorrhoids or fissures or discomfort, let alone anal sex. And rarely do health workers talk about it themselves. That's even with people with HIV. Providers generally don't bring it up. And you can see some of the evidence here from one of the studies. The other thing is that a lot of symptoms of anal health problems go unnoticed and then undetected by healthcare. They don't have any symptoms, and healthcare providers aren't screening for them. So then people don't even know that they've got an issue. So you can see a large part of benign anal health issues like fissures or fistula or hemorrhoids, things, dermatosis, that are not infectious diseases are asymptomatic. And of people diagnosed with an STI, sexually transmitted infection, who had multi-site testing, almost all of them were positive at some extragenital site, meaning orally or anorectally. Another thing is that about a third of women report having had anal sex. And then there's this incredible study that was done of almost 8 million women who were screened for STIs, and less than 0.1% of them were screened anorectally. So I also am trying to communicate in this slide, this is not an issue just for gay and bisexual men. This is certainly a women's health issue, but it's really a health issue for anyone who could be having anal sex, regardless of their gender identity. And then also there's anal cancer is something that's elevated among people with HIV, and screening for that doesn't happen enough. So they're just some of the public health reasons why we should do something about this, and why pleasure and health might be a topic for us to discuss with patients. So this all led to the development of a project called Partnering to Enhance Anal Health Communication and HIV-Related Evidence-Based Services. That's like an NIH title, so it's very long, but the shorthand of it is, it's called Peaches. And here's like a nice little image of a couple of peaches, but really what we're talking about is this. We're talking about sex. So I'm going to walk you through what we did in this Peaches project. It was funded through the National Institute of Mental Health, and it was a project that I had that ended just in December. And I'll tell you about a future project that hopefully, knock on wood, is going to be funded soon. It involved training and also quality improvement. So there was a workshop, the workshop I mentioned to you before, and this is like a little bit of a window into that workshop. That's to enhance people's knowledge and comfort and skills. Then coaching calls for about 3.5 months to reinforce those skills and the knowledge too. And then we wanted to create some changes within clinics too. And to do that, we did two things. We gave people materials to place in the clinic environment. I'll show you that on the next screen. And then we had quality improvement meetings. If you ever want to learn more about this, the outcomes of this research, on our website, I've got a presentation on the outcomes of that. Here's an example of some of the stuff that we asked people to put up in their workplaces. So here's a poster which says accurate, reliable, sex positive tips about anal sex. Actually, the original poster said just the tips about anal sex, but the clinic said, ooh, that's a little bit too hot for us. Can you change the title a little bit? Everything else here is the same. So you can see it's also linked to our website, so people can scan it and access the website. And then over here are certificates. Here's a certificate, and here's another one. And you see this pride flag over here. So I'm just pointing out that if you want people to be able to talk about anal sex, it's one thing for you all, for example, to come to a 90-minute webinar, or for people to come to a 2-day in-person workshop where you can learn knowledge and skills and practice those and how to communicate. And that hopefully will improve your ability to actually interact with another person or people. But the problem is that when it comes to actually being in the clinical environment, people get a little bit shy around this topic, even if they have the knowledge set and the skills. Providers still feel like, I don't want to step on my client's toes, and clients don't know that you've got that knowledge set and those skills. So just like a pride flag says, hey, you know what? You can talk to us about being queer. It's okay. We can be open about that. Having something in the environment also communicates, hey, you can talk about anal sex with us. We can talk about it in a way that's focused on pleasure, not just asking whether you've screened for STIs and HIV. Okay, so the workshop focuses on a couple of different things. The basics are about anal physiology during anal sex, and then also ways to communicate. And the basics are what we're going to cover today in the bit of time that we've got left: physical structures and sources of pleasure and answers to frequently asked questions. And then the ways to communicate are based in motivational interviewing and gain frame messaging. And then also we trained people in sexual history taking using this goals approach, which is also available on our website. But I think now it's time for us to get into the basics ourselves. So let's get into the but what of this. I'm going to pause for a moment and just see if anyone has any questions about anything I've covered so far. Allison mentioned I'm a clinical psychologist, so I've been trained to be comfortable with pauses and silence, but I don't want to go too long, just in case.
No questions in the chat yet, Bryan.
Okay, great. Thank you, Allison. All right. So here are some of the questions that you had here, right? I'm going to also allow you to vote. So you can start voting if you'd like to about any of those particular questions while I start to go over some of the basics. That's just so that we make sure we get to some of the highest priority questions that you've got. Again, we've got our website, and here I'm showing you what the website looks like. I'll walk you through it by the end of our time together. We're going to go over some of the what here in terms of the prevalence of anal sex, who's actually having anal sex. So you see a lot of images here. What does this suggest to you when you see these images? It's okay if you don't say anything. I'm happy to share, but I see something in the chat, so I'll check it out.
Been going on since the beginning of time.
Yeah, exactly.
Long time come.
Exactly, right? You see things, so these are some ancient images here, right? You also see things that are happening across genders and gender identity, and cultures and time, and you've even got a little bit of outer space here in the future. So it suggests that this has been going on for a long time, and that all across the planet, people have engaged in anal play. Now, when it comes to what we know about anal sex, there's some stuff where we have a lot of data and we know a lot that's science-based. And then there's stuff where we have some stuff, we've got some data that's either science-based or practice-based or lived experience. And then there's stuff that's just completely data-free. So I'm going to do my best to communicate when we know something really based on the science, when we know something based on practice or a combination of a little bit of science and some practice and stuff that we just really don't know. Okay, this I'm sharing. We have already made this point that that women are having anal sex, but I just want to share this with you in case it's helpful if you ever need to communicate this to anyone else in your life. I had to communicate this to my father because he didn't believe me that women were having anal sex, so I had to show him these slides. Okay, so if you compare a color on the left to color on the right, what's the take-home message? So what you see here, it's very binary in this case in this study, but this is asking about like have people had anal intercourse, receptive anal intercourse in the past year? And here you've got men and here you've got women. Okay, so if we take this bracket, which is people aged 20 to 24, what you see is 5% of men say they've received anal sex and 23% of women say that they've received anal sex. And you see across all age groups, it's really lower for men than it is for women. So it's pointing out that far more women than men have received anal sex in the past year. Now, this is not telling us how often people are having anal sex. It's just saying in the past year, have you had it? But by absolute numbers, there are more, quote, heterosexuals who've had anal intercourse than there are homosexuals, just by virtue of like the number of men on the planet, the number of women on the planet. Another thing is that this prevalence of who's having anal sex really depends on how you ask people. So let's just imagine this. You don't respond in the chat, but if I were just to ask you right now, by a raise of hands, who's had anal sex? Raise your hand. Don't actually do that unless you really want to say you're welcome to, of course. But I would imagine some of you might feel like, yep, I'm ready to say it. And other people might be like, I have, but I don't know if I want to say that in this setting or to anyone else. I'm not sure if I want to. Or maybe I'm curious about it and haven't done it yet. That's because it's how you ask people. So in this study of prevalence, let's take a look here. This is among married men in Benin in Africa. And FTFI stands for face-to-face interview. So when people were asked face-to-face, have you had anal sex? 3.5% of them said that they'd had anal sex. But when they were asked in a polling booth in a survey where there was not another human being directly across from them, that was 5 times higher. So the prevalence is higher when people are polled privately or asked privately, which also suggests to us that even when you ask your clients, or even if you are a client and are asked by a provider, you may not feel comfortable saying what you're actually doing, or your client may not feel comfortable saying what they're actually doing. So we have to do something about this to help people feel more comfortable talking about it. I see the chat too. Yes, Lisa, it does point out stigma. Yep. And I see also, David, your question about bidets. So hopefully we'll get to that one too. Okay. Another thing about the science here is that surveys tend to ask about anal penile intercourse. So if you're seeing my face, basically like, here's a penis, here's an anus, they're just asking about this. They're not asking about other ways that people engage in anal play, like oral anal play or with toys or fingers or other objects. There's also very little reliable data for lesbians or trans and non-binary people. I've only seen one study that talks about the prevalence of anal sex among women who have sex with women, but I haven't seen anything that's really reliable in terms of prevalence for trans and non-binary people. Certainly, there's a lot of science, though. There's a lot of science and meta-analyses and reviews about HIV risk. That part we know. It's just that we don't really know other aspects of how people are engaging in anal sex, how often they're having it, what they're actually doing. So we're missing a lot of reliable samples for most regions around the world. We also really don't know how often people are having it, and there's really no global prevalence of anal intercourse or other forms of anal play. So we're lacking quite a bit of knowledge. Let's go over an overview of anal sex physiology. So with this, what we're going to do is start with the structures, the rectum, anal canal, and anus, musculature, sphincters, the puborectal sling, pelvic floor muscles. Allison mentioned that you had a public floor specialist come and talk before, so you all might have some knowledge to share on this front too. Sources of pleasure, we're going to talk about the prostate and clitoris in particular, but there are other sources of pleasure as well. Lubricants, And then we're going to talk about poop because that is one of the things that people are particularly concerned about and how you can manage those concerns. Okay. Let's go over here first and just see how people have voted. I'm going to finish voting. What's normal to feel, how to stay healthy, non-judgmental ways to talk about it. Can you have anal sex if you suffer from hemorrhoids? Okay. Oh, I see the voting here. Voting didn't quite, you know what? Just like our democracy, sometimes voting doesn't work out. So here we go. We're just going to cover some of the basics, and then I'm going to rely on you all to raise questions as you have them. You can put them in the chat because I can see that, or you can unmute as well. So here's some basic anatomy. Right now, you're looking at a person here facing front, and you can see the transverse colon, you can see the descending colon. Basically, here's the colon, this part here, that almost looks like a box, right? And then it transitions into something called the sigmoid colon. And then you've got the rectum here. And then over here is the anal canal. We're going to talk about each of those and why they're relevant for pleasure. So the colon's about 6.5 feet long, but you notice it says about 6.5 feet because there's people vary, right? Like one of our amazing features as a species is that we're really, really diverse. So it could be 6.5 feet, could be a little bit longer, a little bit shorter. The sigmoid colon is the S-shaped end of the colon, just here, and it leads into the rectum. I'll show you another image of it. So this is as if this is looking kind of from the front, and this is if you were looking in the back. So here's the spine. You know, it sort of curves back here. So here's the anal canal here, anal opening, also called the asshole. Some people use that word. Here's the rectum. And then here's the sigmoid colon. And what I want to point out here is that the rectum is about 5 to 9 inches long, varies again, person to person. It's about 1.5 inches wide and it stretches. And it fills with poop and gas right before release, but it's generally empty at other times. So fecal matter, poop, feces, shit, whatever term makes sense for you to use, travels down the colon and then stops just about here at the sigmoid colon because of that curve. And when there's enough of an accumulation, then it moves into the rectum. And moving into the rectum is the moment when you tend to feel, oh, there's something in there that I need to release. That's your rectal reflex. It's your body communicating with you. There's something inside of me to release. But otherwise, you'll notice, you might even notice right now, it doesn't feel like you have anything to release. That's because there's very little fecal matter or gas to release. Generally, if you have enough fiber in your diet, there's not any sort of discernible, visible signs of fecal matter in this 5 to 9 inches. Okay, now this is quiz time for you all. If this is 5 to 9 inches, and generally there's not a lot of like poop left over in here if you've got enough fiber in your diet, but then here's the sigmoid colon, and the poop is kind of behind here, accumulating and moving into the rectum. What happens if you introduce an object that's more than 5 to 9 inches long into the rectum?
It's going to have
What
poop
could
on
happen?
it. It's going to have
Say it
poop.
again, Jessica.
It's going to have poop on it.
It may, depending on when you ate last, right?
Yeah.
It may, right? But there's a greater likelihood of that. So if someone's engaging in fisting, for example, where they're introducing a fist into the anal opening, past the anal canal, into the rectum, and then get past that and into the sigmoid colon, you can imagine that's a greater likelihood of contacting fecal matter. Likewise, if you introduce an object, I mean, what's the average size of a penis?
About 5 to 9-ish.
Yeah, right? I mean, the average is lower than 9, so it's around 6. But you can imagine, right? People vary. So some people have a rectum that's 5 inches, some people have one that's 9 inches, right? It could be even more or less. So depending on the size of the object that goes in, you may increase the likelihood of coming in contact with fecal matter. And we'll talk about how you manage that. Okay, here's another image. Here's the colon again. Here's the sigmoid colon. Here's the rectum. And you can see the anal canal is just at the bottom here. And that's what we're going to talk about next. Just this little pink spot. That's the anal canal. It's the first few inches beyond the anus. and the anus is just the anal opening or the asshole. It's got two rings of muscle called sphincters, and they close and open the anal canal. So, where else do you have a sphincter that you all know about in your body? Anyone else know about a sphincter? If you can see me, I'm pointing to it. It's your mouth. It's a ring of muscle that opens and closes. Now you can open and close your mouth pretty easily, right? You got a lot of facility with that. When it comes to these other two rings of muscle, you can't open and close them in the same way that you can your mouth. But one is more voluntary, like the ring of muscle that's your sphincter of your mouth, and one is more involuntary. So it's a little bit more difficult to just, you can't just open it at will. You have to actually do some things like breathe deeply, relax, experience stimulation for it to open up. Here's another image of the anal canal. So here's the anal opening, the anus. Here's the rectum. Here's that curve, which is the sigmoid colon. And then you've got two rings of muscle. So this is almost like someone's kind of sliced in half here. So here's the external sphincter. That's the outer ring. And then you see here's the internal sphincter, the inner ring. And the outer ring is the one that's a little bit more, it's a voluntary muscle. It's a little bit more under our control. The inner one is not under our control, not part of it's part of the autonomic nervous system. So let's talk about the anus, also known as the asshole. It opens to the anal canal. It's very densely packed with nerve endings, and it's very sensitive to touch. So if you would do me a favor, take your hand for a moment, any hand, and just hold your palm up. Thank you, Yang, for doing this because I can see you. And then if you just take a finger from the other hand, I'd like you to just touch the inside of your palm. Just touch that. I think maybe I can see you too, Kimberly, doing it. Thank you for doing this and being participatory. Now flip your hand over and touch the top of your hand. What do you notice? What's the difference?
The
Yeah, I see
texture
Kimberly, you
feels
responded.
different.
Yeah.
The texture feels different.
Mm-hmm. The sensitivity is really different. And I
Sensitivity.
see some people in the chat saying too, I can feel more, there's less nerves on top, it's the texture, it's more sensitive in the palm. Exactly. So your palm is more densely packed with nerve endings than the top of your hand. And the anus itself is very densely packed with nerve endings. So it's very sensitive to touch. Now, what does that suggest? It's very sensitive to touch. What does that suggest? Well, it's a little bit like, if someone touches the palm of your hand, right, versus touching the top of your hand. It doesn't mean that, anyone in the world just touching the palm of your hand is going to be sexually arousing for you, right? That's not the case. We know that's not the case. So similarly, just because you've got a lot of nerve endings at the anus doesn't mean that anyone touching it or you touching it yourself is necessarily going to be stimulating. It just has the potential, or arousing is what I mean. It is stimulating because it's very sensitive to touch, but it may not necessarily be sexually arousing. It depends on more things. Now, I also want to point out something that I didn't share before, which is about the rectum here. Okay, when I said the rectum fills with poop and gas right before release, it's generally empty at other times, but it also stretches. So the rectum doesn't have the same density of nerve endings as the anal opening does, but you do sense when it fills. And you might even notice, I'm going to be candid with you all, I feel comfortable in your company. You might notice that when your rectum fills, for example, if you have a big poop and it fills, and then you release it, first off, you can feel that it's there, right? But then when you release it, you might notice, oh, I get kind of chills when I poop. If you really pay attention, you might notice that. And that is partly because you're experiencing the rectum empty, so you can sense when it's emptying, but also it's going through the anal canal and then it's coming in contact with those nerve endings in the anus. So that might be stimulating. I encourage you the next time that you go to the bathroom to see what it feels like. Okay. So nerve endings. So this also suggests that anyone with an asshole has the potential to feel anal pleasure, regardless of what sex they were assigned at birth, or their gender identity, or their sexual orientation. It really has nothing to do with those things. It's just a physiological response, similar to if someone touches the palm of your hand, you will have a reaction. I mentioned that the outer sphincter is a voluntary muscle, so you can control it at will. It's kind of like your mouth, but obviously not exactly like your mouth, because it's not, you don't have the same ability to open and close it in the same way. The inner sphincter is involuntary. You have to relax to open it. So I want to point something out here. It suggests, this is to be more scientific about it, the voluntary muscle means it's part of the sympathetic nervous system. The involuntary muscle means it's part of the parasympathetic nervous system. What else is part of the parasympathetic nervous system? Or involuntary?
GI tract.
Oh, sorry, Allison, go ahead.
GI tract.
Yeah, your GI tract. Yep. You don't control that, right? It's just happening automatically. Another thing is your emotions. Also, you don't control your emotions. They just fire when they fire. How you respond to your emotions is a different thing. It's more voluntary. But there is something to be said about your emotional experience and care during anal play, because you might notice if you've ever experienced sex, even regardless of where it is in your body, that sometimes your relationship with the people you're having sex with influences your level of pleasure and your physiological arousal. And when it comes to anal play, the arousal is oftentimes about your relationship with other people, not just about stimulating something. It's similar to the idea that, like, I don't think anyone would say, oh, if you just put a finger on someone's clitoris, they're just going to get excited, right? Or you put a finger on someone's penis and they're just going to get excited. It's not how people respond. Now, some people do get excited that way. So there's a lot of variability, but in general, we have to consider people's emotional experience as much as the physiological experience too. Another thing about the anal canal is because of this involuntary muscle, this inner sphincter, if you introduce an object past the anal opening and into the anal canal and then comes in contact with the rectum, you want to make sure it has a flared bottom. So here's an example of a toy, a butt plug, that's going inside the butt, past the anal canal, anal opening, anal canal here, and then rectum up here. But it's got a flared bottom. And that's because this inner sphincter muscle can start to spasm. And if it starts to spasm, it will pull objects inside the body and then move them up into the rectum, into past the sigmoid colon, and possibly further up. So that's why anything that goes in should have a flared bottom. So obviously a hand already it's attached to something, so can't go in further. But a cucumber, not something to put inside inside of the butt, because it can migrate up. Okay. Let's see if there are any thoughts or questions about anything I've covered so far.
Nothing in the chat.
Okay. Thank you. All right.
I think we're having some side conversations about urban myths about gerbils and all kinds of stuff, and now I'm having it mix all these stories that you hear, and that makes sense. But thanks for explaining.
Yes. Okay. Let's just talk about gerbling for a minute. Okay. So I've not seen any science about gerbling, but I will tell you, in something like first or second grade, I heard this myth that, and this is in the 80s. Okay. So I grew up in the 80s. This is like 40 years ago. I heard this story about an actor, well-known actor, who is really into gerbling. In second grade, I heard that story. So somehow I heard a story that involves something related to anal play. And yet when it comes to anal sex, very few people are talking about it. We really only tend to talk about it when it's extremes. We talk about it when, oh, well, that's how you can get HIV or STIs, or you can have problems with, hemorrhoids, or gerbling, that's extreme, or fisting, oh no, people do that. We talk about it in that sense, but we don't really just talk about it in a sense that is like, it's just normal everyday things that people engage in. And most people are having anal sex are just engaging in anal sex, not in any sort of extreme way. And I'm not suggesting, as I say this, that fisting in and of itself is extreme. I don't mean it that way, but that our minds tend to go to things that we think are extreme, And we talk about those, but we don't talk about much of the stuff that's sort of in the middle.
Just to follow up on that point, you said we could talk.
Please.
I just think because I put the name in the chat because I remember that it was
Yep.
Richard Gere, right? And it was this whole thing, and it was this whole sensationalized thing, and nobody ever connected it to anybody, to kids or a teenager, whoever, what it could have been and what it was, and imagine that that was an opportunity, right, for to
Mm-hmm.
educate and what have you, and it ended up turning out to be this thing that supposedly shamed him versus a
Yeah.
conversation that could have moved in a different direction, particularly the time that it happened, which was the early
Yeah.
80s, where there was lots of things happening with HIV, and it would have been a perfect segue to say, yes, that's something that some people do, and here's how to make it safer and what have you. Instead, it was this, he was shamed, and I think he probably lost movie roles because of it, instead of it being sort of a societal conversation.
Yeah. Spot on, Allison. I didn't say his name
I
because I
did.
thought, I know you did. But what's so funny to me is that I grew up in Texas. I don't know where you grew up, but somehow we both heard this, unless you grew up in Dallas, Texas,
Nope.
too.
Nope.
Somehow we heard the same thing, right? The message carried, which is also kind of speaking to how sticky stigma is. That when someone gets labeled with something and it's a bad label, it really sticks and it kind of carries like fire. Okay. I see another chat. How can I? Okay. How can I encourage our patients to know it's okay to have these conversations? So, Melissa, I see that question, and I think it's something that people raised in the Mentimeter as well. And I just want to address this now. So, the message that I've learned from the research that I've done is that you can train people providers to increase their knowledge and their skill set, and also their comfort and confidence talking about this, which is really lovely, right? So like after this talk, maybe you're going to feel a little bit more confident talking about this. The problem is that if you expect patients to be able to talk about it too, you have to do something in the physical environment that signals to them that it's okay to talk about this. So that's why we have that website. It's why we had those posters. If you can see my image, it's why we had these are little, it's like a little squeezy peach that's got our website label on it. It's why we had these buttons and pins. We had stickers. We had business cards. We had all sorts of things for people to put in the physical environment. Those resources are also available on our website. Not all of them, but the ones that you can print readily yourself. And so my take-home message from the science of studying this is do something in the physical environment. You have to, of course, increase your knowledge, comfort, and skill yourself, communicating about it. But also you have to put something somewhere visually so that patients know it's okay to talk about this. It's okay for them to bring it up. It's okay for you to bring it up and then offer them a resource, which very often, at least with our resources, are linked to something that they can access even if they don't feel comfortable talking about it in the moment. And thank you, Yang, for putting up the website. Yes. And also thank you, Allison, for mentioning that it's a 90-minute webinar. I think the invitation went out automatically for 60 minutes, but we're going for 90 minutes. So of course, if you need to dip away, do what you need to do to take care of yourself. But I think it's recorded, so you'll be able to watch it later too. All right, time for a little bit of a video.
This is where your ice cream comes from. The creamy poop of a mystic unicorn. Totally clean, totally cool, and soft served straight from a sphincter. They're good at pooping. But you know who sucks at pooping? You do. That's because when you sit on a porcelain throne, there's muscle puts a kink in the hose and stops the Ben & Jerry's from sliding out smoothly. Is that a problem? I don't know, are hemorrhoids a problem? Because sitting at this angle can cause hemorrhoids, bloating, constipation, and a buttload of other crap. And seriously, unicorn hemorrhoids? The glitter gets everywhere. But what happens when you go from a sit to a squat? Voila! This muscle relaxes and that kink goes away faster than Pegasus laying sweet sherbet dookie. Now your colon...
All right. I'm not trying to sell you a squatty potty, which is what this commercial is about. But what I am trying to do is point out this muscle, which is called the puborectal sling, also called the puborectalis. And it's a muscle that very few people learn about. When I was trying to understand this topic to be able to teach people about it, it was the first time I'd ever heard about it, even though I'm someone who had engaged in anal sex many times before learning about it. So let's learn about the puborectal sling. So here's another image of that muscle. And I want to point out, this is the pubis. This is the front of the body. Okay. Here's the tailbone. So the spine's kind of going up here. So front and back. And then here is the anal opening. You see the internal sphincter and then the external sphincter that's wrapped around it. So that's the first couple of inches here. Then you see the rectum here. And then further up here would be the sigmoid colon, then the colon. And what I want to point out is you see how this muscle is kind of cinching forward? It's pulling the rectum forward and it's creating that first curve in the rectum. And when it's cinched forward, you see how it's kind of like this angle is kind of, it's much, I don't know how to talk about angles exactly, but it's much more closed here. Whereas when this muscle is relaxed, it's much more open. So if you imagine anything leaving the rectum or entering the rectum, what would happen if something is trying to enter the rectum, but this muscle is pulled tight? Well, it would enter, but it would kind of hit against this wall of the rectum. Whereas if the muscle's relaxed, it can get in and actually go in and out with some pleasure associated with it, which we'll talk about a little bit more when we get to the prostate and the clitoris. So this is the puborectal sling. It is responsible for about 80% of the ability to hold in gas and fecal matter in the body. I thought originally that that was the responsibility of these two sphincters, but actually a lot of it rests with the puborectal sling. And it's relevant when it comes to anal sex in part for two reasons. One is that in order for an object to go into the rectum, you have to be able to relax this puborectal sling. And also how you relax it depends on the position of the body. So you see how this unicorn is the stand-in for a human being, is squatting. In this squatting position, that's how this muscle starts to relax. So here's another image. Here's the internal sphincter. Here's the external sphincter, the anal canal. These are the anal canal. These form the anal canal. This is the anal opening of the asshole. Here's the rectum. Here's the sigmoid colon. So when gas or shit leaves the sigmoid colon and fills the rectum, that is when we feel the urge to relax and release. That's known as the rectal reflex. So fullness in the rectum is what communicates to this muscle, this puborectal sling, that there's something inside and that it's time to relax. So when you relax it is when you start to be able to release gas or fecal matter. And likewise, when you relax it is also how you allow something inside of the body. Okay. Now, what disrupts the rectal reflex? One thing that disrupts it is our diet. So if your bowel movements are properly full, if your fecal matter, poop, is properly full, what happens is it travels past the sigmoid colon, it enters the rectum, you get a sense of fullness, and then you release. And you might get those chills that I mentioned. If you don't have enough fiber in your diet, or if you're constipated, so if you don't have enough fiber in your diet and you have loose stools, what happens is kind of a slow trickle from the sigmoid colon into the rectum, and you have a sense of like, oh, there's something in there. You release, but you don't have a sense that everything's released, and you then might want to push or feel the urge to push to try to release everything that's in the rectum. Likewise, if you're constipated, your body's trying to push the poop through, and you might feel something like a small pebble or something rather than a full bowel movement. And then again, you might be pushing. Now, the issue is that if you're pushing, you're communicating to your body that the way that you actually release something and relax the puborectal sling is with pressure, as opposed to if you just allow things to properly move through the body. So as a homework assignment, even though you may not be able to change your diet overnight, as a homework assignment, if you're someone who regularly pushes when you have a bowel movement, your homework assignment would be to sit on the toilet or wherever it is that you sit or squat, and just see what happens if you don't push at all. See how your muscles respond. Very likely what will happen is your puborectal sling muscle will relax. It will relax. It will release that first curve in the rectum. Your anal sphincters will also relax and open, and you'll just release. That is a similar thing to what we're asking people to do when they're engaging with in anal play is also to be able to relax, to enjoy the experience. Here's another image of the puborectal sling cinching forward, just if you wanted to see a little bit more detail of the anatomy. And then here's another image of that, but I'll skip that one for now. And again, here you see that in a squatting position, in a sitting position, you see it sort of cinched forward. In a squatting position, it relaxes a bit and allows a little bit more of a little bit straighter line here into the rectum. Another image of the purectalis. This one is if you were looking from the top of my head, and here's my spine, here are my hip bones, and then you can see this is the puborectal sling. So it looks like it's just sort of one rope, but it's forming part of the pelvic floor muscle. Okay, I think I'm gonna skip that one for now. I'm gonna get into the sources of pleasure because this also has to do with what will help your puborectal sling relax and also help people relax their internal sphincter as well. So this is an article that came out in 2022 about the clitoris that was in the New York Times. And when I was first trying to educate providers on this topic I think it was like 2010, 2011. And that's when I discovered that the clitoris is not just what's underneath the hood, but it's actually got legs and bulbs. Up until that point, I'd never been educated about that. And apparently not many people had because people were not talking about it. So I'm going to show you a little video about that.
The body is absolutely boggles my mind. Now, I've spent a lifetime drawing the nude. And when I actually discovered the internal clitoris, I think it was in the early 90s. So this is the internal structure of the clitoris, the leg of the clitoris. It's like a wishbone. Shaft of the clitoris. Clitoral glands. The bulbs of the clitoris that go down deep in the body on either side. We have nearly as much erectile tissue as men. We get erections too when we get turned on. But because it's internal and most of us have been so badly repressed that we don't even recognize when it's happening. And here we have vaginal opening, urinary tract opening, inside the body. This is all inside the body. There's the perineum. It's a space for a man it's between his asshole and his balls, and for a woman it's between her asshole and her vagina, the perineal sponge. Best of all is in the little, this is 8,000 nerve endings here, so this has got a lot. You can feel your clitoris get an erection. Well, let's go on down. I don't want to leave out the asshole. I must say I'm quite fond of the little buddy hole. It's cute. Here's the PC muscle. When you tighten your PC muscle, and you can feel it in your clitoris, and in your vagina, and in your anus, then we can deal with the external. So here we would have outside. This would be pretty closed. You wouldn't see too much. And we'd have the inner lips, hopefully nice full ones. They're my favorite. Oh, outer lips. Now you're not going to see much of the pee hole in here, and the vaginal opening will be not easy to see either. Oh, I just can't control myself. It's different in absolutely every woman. It is amazing.
All right, a little illustration, but that's in 2 dimensions, and I'm going to show you some images that hopefully help you see a little bit more in 3 dimensions. So here's the clitoris, and this is the part of this is the glands, the part that you can see from outside of the body, underneath the hood. And the rest of this is internal to the body. And you can see that there's the bulb, you can see the crus as well. And I would just want to point out that these are very, very similar structures in the penis. So you see how they're parallel structures, right? There's just differences in terms of what you can see. I also want to point out here, this is an image from an article that came out a couple of years ago. This is someone, a transgender person who's got a neophallus that's been surgically constructed and has a clitoris. So the clitoris is still there. And I want to point out something here. You see how the bulbs of the clitoris extend back? This is the pelvic floor, they extend back. And then this is the anal opening, the anal canal. So you can see the external sphincter and the internal sphincter. And then here's the rectum. So you notice if these fingers are in here, they could be stimulating the bulbs or the legs of the clitoris internally. And that can be a source of pleasure for people who have a clitoris. Whether they have a neophallus or not doesn't really matter. If they've got a clitoris, then they can be stimulated in that way. They may find that pleasurable. Here's another image, and this is someone who has a clitoris but not a neophallus. And similarly, this is looks like this is a penis attached to a body. And so you can see something going inside here. So imagine the sources of pleasure could be the anal opening, for one, because that's the palm of the hand, like the palm of the hand. Then also, if you're able to relax the internal sphincter, it also suggests that you experience some kind of emotion related to being able to relax it. It's part of your autonomic nervous system. So typically it's arousal or stimulation, something that is pleasurable in some way, allowing that to open. And then also the feeling of fullness inside of the rectum is another source of pleasure. Similar, if you've not had any anal play at all in your life, it's similar to what it feels like when you have a poop that's inside of your rectum and a sense of fullness. But also it's because it's stimulating the legs of the clitoris here. Here's another image. This is a little yellow part is the glands that you can see here. And then here you can see the other structures in blue of the clitoris that are not seen because they're inside of the body. Okay, let's talk about the prostate as well. So sometimes I've heard from people when I'm bottoming, receiving receptive anal play, it feels like I'm going to pee, then like I'm going to ejaculate or come, but nothing is coming out. What's going on? And the answer here has to do with the prostate. I'm going to point out something here as well. So here's a penis, and then here is the bulb of the penis. And it's very similar in placement to the bulbs of the clitoris. So likewise, a finger, an object, a toy, a penis going inside the anal canal and rubbing up against here could stimulate the bulb of the penis. And some people describe it almost as though they're being almost being jacked off from the inside because their penis is being stimulated, even if they're not touching their penis at all. And in fact, it's quite often the case that people who are experiencing anal play, if they're not stimulating their penis could be flaccid, but they still could be experiencing quite a bit of pleasure. Another source of pleasure has to do with the prostate. And the prostate is the muscle that is responsible, the muscles around the prostate are responsible for the sensation of orgasm. Now, when the muscles squeeze around the prostate, usually that's associated with ejaculation. But squeezing of the prostate without ejaculation can still feel very pleasurable, like orgasm. Now, you see how this finger is pressing against the prostate? The recommendation is not to poke, but to actually rub, similar to how you would rub and not poke the legs of the clitoris. It's also right next to the bladder. So something presses against the prostate, you're also likely pressing against the bladder. And that's why people sometimes experience a sense of like, oh, I have to pee. Because as the bladder gets pressed, it feels as though the bladder is more full, even if there isn't any urine to release there. This is just another image of the prostate. And you can see its location here, penis here, testicles here, and anal canal and rectum. So sometimes people refer to this as the P spot, because if you rub against the prostate internally, then it feels quite pleasurable. It also can feel like you might have to pee, but most people refer to it as the prostate spot. And here's another image, and you can see the bladder emptying, and it's going through a tube through the prostate and then out through the penis in that case. Okay, so rubbing the wall can produce orgasm or heighten orgasm, and that's for people who both have bulbs of a bulb of the penis or who have the bulb of their clitoris there as well. It may feel like peeing at first. It's like the G spot. This P spot in someone who's got male anatomy is like the G spot in quote unquote female anatomy. So people sometimes call it the P spot. It's not the sole source of pleasure, as I mentioned, right? Because there could be stimulation of the anus itself and that tissue there, but also just a sense of fullness in the rectum can also feel pleasurable. I mentioned before, orgasm results from the muscle contractions around the prostate, even without ejaculation. So ejaculation and orgasm can be distinct experiences. Someone can experience a lot of pleasure, even if they're not ejaculating. Even it can feel like a whole body orgasm, similar to what people with a clitoris have described themselves, even if there is no ejaculation in someone who's got a penis. The prostate is also, it's about the size of a walnut, but it's not hard like a walnut. It's more like a blackberry, not like the old phone, but like the fruit of a blackberry. It's got these sacs of fluid, and when squeezed, they release that fluid. And I mentioned the bulb of the penis is there as well. Okay. Another image there. Another image here. I'm going to skip that for now. Here's an image of just a toy that can be introduced. In this case, this is someone with a penis, but it doesn't really matter whether the person has a penis or likes the clitoris. There are different toys that try to stimulate differently, but any toy can potentially stimulate that area. This is an example of a toy that's sort of designed to use the pelvic floor muscles to then press against the prostate and stimulate. So we're going to talk about the pelvic floor in a bit, but I wanted to show you these images. These are from that article that I mentioned that came out in 2022. There's some really incredible images here. I've never seen images like this in a peer-reviewed paper before. And the authors, name of the first author is Daniel Dickstein, and he had these images created, and it's a very thorough article about sources of anal pleasure from a medical perspective. And actually, it's also about radiology and trying to preserve the ability to experience pleasure for people who might be going through cancer treatment. In this case, you see the prostate. I think it's kind of funny that they made it look like an eggplant. So it's a little bit of a emoji there. But you can see this. And in that article, there are more images. I think I've got them later here as well. This is someone who's had gender reassignment surgery and has a new labia, but still has their prostate intact here. So here's their vagina or neovagina. And you can imagine, you can see here now, stimulation through this neovagina or new vagina is coming in contact with the prostate. So even though this person doesn't have a clitoris, this friction over here inside of the vagina, as well as possibly in the rectum, can stimulate the prostate and give that person a sense of orgasm. This is the article that I mentioned by Daniel Dickstein. Here's another image, this time with a toy. And this is also someone who's got a neolabia, neoclitoris, and neovagina as well. And this is someone with a neophallus. I think I showed this one before. Okay, let's talk about pelvic floor muscles, and then I think we're going to have time for just open questions. So you've had some of you have had some exposure to pelvic floor information. If you're enjoying anal sex without pain, you are exercising these muscles. And there are things that you can do, like Kegel exercises, to increase blood flow and muscle tone and control and intensity of orgasm. In some people have too much muscle tone there, so it's not recommended that they do Kegel exercises. But in general, what you can do is exercise these muscles in a way that increases blood flow and also your ability to control a little bit more your orgasm. And I'll just point out, this is a clitoris and then a penis, and the muscles are very similar across anatomy. If you haven't done any Kegel exercises, they're very simple to do. In fact, we'll just do one now. If your doctor's told you not to do it because your muscle tone's too tight, too high, no need to engage in it. But if you just imagine that you're about to pee and then stop yourself from peeing, those muscles are the muscles that are highlighted here. You are contracting those muscles. And very often it's the pubococcygeus muscle, but when you stimulate any of these muscles to contract, you're often stimulating all of them to work together in tandem. It's possible to also strengthen your orgasm by strengthening these muscles or the coordination of these muscles, so that as you're approaching orgasm, you can slowly contract these muscles and keep yourself from reaching orgasm, to plateau more before you orgasm. Okay, I'm going to skip numbing agents for the moment. I'm going to skip this for a moment and get to your questions that were related to, I think, substance use. I'll just mention douching. It's very popular. And it's very popular that people use douches, particularly gay and bisexual men. Almost all of them have used them at some point. Some people report problems with douching, and there's more science that's coming out about douching and kind of what the recommended practices are. The best knowledge that I've got so far is if someone is going to introduce liquid inside of the rectum to try to wash it out, that it should just be about the size of a small water bottle, that amount of liquid, and only 3 times doing it, not more than that. But there's not a lot of great science yet on this. Things are being studied now and soon should be published. But the take-home message is that people are doing it. So it really is something to talk about in terms of harm reduction with your patients. Alternatively to douching, it's not necessary to douche, because I mentioned before that the rectum generally is free of fecal matter. And so if you increase your fiber content, generally for most people, that can be sufficient enough to keep the stool properly bulky, so that when it leaves the sigmoid colon, enters the rectum, it's properly full, and then it all leaves the rectum. But if someone's committed to douching, then the recommendation is just to use warm water and a smooth-tipped, lubricated device a few hours before sex. The fiber here is because the apple is here because in a training once, someone came up with an expression, an apple a day keeps the shits away, as a way of helping patients remember to increase their fiber content. You can also use supplements like psyllium fiber, chia seeds, other things that may be more or less agreeable to particular people. So you have to kind of titrate how you're going to do that yourself. It's really an experiment to see what works for you. Here's an image of what fiber does.
It works like a sponge going through your body so that when you go, you fully go. This, of course, reduces prep time and makes you more comfortable and confident.
It's a bit of a fast image, but what's happening is that the fiber is bulking up fecal matter. And what
it works like a sponge going through your body so that when you go, you fully go. This, of course, reduces prep time and makes you more comfortable and confident.
And then exiting the body. Okay. I just mentioned this now, which is that there is an internal condom, formerly called the female condom. And I call it the internal condom, and a lot of us call it the internal condom now because it can be used for anal sex. And in fact, this is an FDA, this is a brochure that was sent to the FDA for the quote unquote female condom or the internal condom. And it was originally designed to be used during anal sex. It never got FDA approval for that. In fact, it was only in 2022 that the first external condom was approved for anal sex. Get that. 41 years into the HIV epidemic, the first condom that was FDA approved for anal sex, when we had one very early on that was trying to be studied and approved for that. Okay. And this is an image. This is a video of how to use the internal condom. Unfortunately, it's been taken down by YouTube, and I can't seem to find it again. So if you're looking for it, I think I've got a digital version that's saved, and you can always reach out to me for that. Okay, I am going to just show you a bit of the website, and then just open it up to be able to respond to your questions that you shared before. So this is our website. This is actually the old version of what it looked like, and I'll say this. We designed this website with a bit of like gum and duct tape and Elmer's glue. So we didn't know exactly what we were doing, but we wanted to make sure that the resources were available. We've now revamped the website a bit, and now this is what it looks like. So you see a bunch of resources here. And what we've done is we've gone through the internet and tried to find the resources that we think are sex positive and involve some level of medical review. And if not medical review, at least they abide by certain principles of justice, equity, diversity, inclusion, and also accuracy. So you see the different resources are here. So you just click on a resource and then it opens up to the website where you can learn more and access that resource. So we have about 31 resources and we're always kind of adding things. You can also search for the resources. We're hopefully adding an AI element to this so that you can just ask a question and get an answer. Right now, that's not available quite yet. We also have resources for health promotion. So we have the visual resources available here on the website, which you can download. These are in English and in Spanish. And then we also have some educational resources for healthcare workers. And this is the webinar, which is similar to what we just did today. I did this a couple of years ago and it's also recorded there. We also have something called a science library. So we've gathered as many of the peer-reviewed articles as we can find, hundreds of them, about the topic of anal pleasure and health. And so you can search through them. You can search through the entire science library, or if there's a particular thing that you're looking at. So for example, I saw Allison, you mentioned something about marijuana and anal sex. You could go here and just see if there's anything that's been studied on that front, and you get our citation manager, and then you can search for marijuana, for example. Just for fun, we also have this butt gallery of images. So if you ever wanted to do some kind of health promotion by just showing something that's very sex positive, these are images that you could use. You also can see who we are and some of our research findings. This is what I mentioned before in terms of what our findings are from this particular study. You can also see our selection criteria, that everything on the website needs to meet our criteria for accuracy and reliability, and also for justice, equity, diversity, and inclusion, and how we define those. And then, of course, you can also contact us, and we have a newsletter too that we'll be sending out in the coming months if you ever wanted to be on that. Okay. So with that, I'm going to stop sharing my slides. And I just want to make sure I prioritize answering at least some of your specific questions. Kathy, I see, just asked, what temperature should the water be when douching? And it's all capitalized, so it sounds very urgent. So I'm going to respond to that. It should be just room temperature water. So like just room temperature. That's fine enough. Nothing hot and nothing too cold either, because if it's too cold, you might be stimulating the body to like seize up. And that's not really what someone wants. You don't want to make the muscles seize up there. Allison, I see your question as well about marijuana use and other substances to help with relaxation. Yeah. Okay. So what I'm going to do is I'm going to try to model the skills that we teach in the 2-day workshop, which is a little bit of a feat in the 11 minutes we have left. So let's see how it goes. These are based in motivational interviewing, and they just might be very familiar to you all because they're often used. But the first thing I'm going to do is ask you, Allison, if you're willing to engage with me, what is it you've already heard about this? And what are your concerns about it?
Yeah. So I think something that you mentioned earlier is that you have to have the emotion and everything there so people can relax. And I think particularly for sometimes some of our younger folks, they are not necessarily always the ones driving the sexual contact, and so there may be they're not completely there. And so then, oftentimes I'm talking about that. Well, what, and trying to get at that piece of it. And are they really wanting to or not? So definitely there's the emotional piece. And so we talk through that. And are you in the right partnership? And is that why you're not relaxed and that kind of stuff? And sometimes it's that they feel like they're in the right partnership, but they are more comfortable being a top and not a bottom. And so then we're talking about that and negotiation and all. So it really depends. But sometimes it's just, I'm having fun, but this part, I need help trying to figure out to relax. So that's why I'm using put your substance du jour in, which opens them to risk and stuff like that. So.
Yeah. Okay, so there's the aspect of this is so beautiful that you're modeling as a physician how you communicate with your clients and you communicate in such an open way. And you're talking about enthusiastic consent in a way, like wanting to ensure like that this is something you really want to do and finding a way to do what you want to do in the way that you want to do it. And then the second thing that I think you're asking about is are there other ways for people to relax? So if they don't want to use marijuana or they don't want to use poppers, poppers are also known as amyl nitrate, and they're a substance that is like comes in a little bottle and you inhale it, and it's a vasodilator. So basically, it relaxes the muscles and allows people to be receptive during anal sex. It's also associated with some other harms. So there are other ways to do this, and part of it is about foreplay. So imagine this is so here's the anal opening, right? So what I often do is I just point to people. I teach people this thing about this sensitivity and this sensitivity, and that let's see how your body naturally responds when you stimulate it yourself, if you're willing to do that. And you can start to see, oh, I notice actually the external sphincter just sort of opens pretty quickly, but then it's hard to get past this internal sphincter. I have to breathe deeply. I might have to stimulate other parts of my body that are arousing for me. It might have to do with music or environment or imagining a fantasy of a particular person that I'm having sex with. And then that allows that to open up. Deep breathing also helps. And then beyond that, there's a puborectal sling to open that as well. So if I'm standing up, then that puborectal sling is cinched forward. But if I'm sitting down, it's a little bit more relaxed. But if I'm squatting, or for example, my knees are at my chest, or I'm almost in child's pose, right? Then that's naturally allowing the puborectal sling to relax. So it's a lot of information that I've just conveyed, Allison. Tell me, what are you making of what I've just shared with you?
I'm making that understanding where somebody's coming from and what their issues are, and then presenting them the repertoire of options of how to potentially address it. It could be positional, it could be time, it could be foreplay, and just sort of talking through because it may be different things for different people in terms of what may get them there.
Yeah, there's no single answer,
Yeah.
right? But you're
Yeah.
doing the right thing by just engaging with people and saying, you can talk to me about this.
Yeah.
Yeah.
Just trying to make sure you went through all the questions before I ask another one.
Yeah. May I just point one thing out?
Yeah.
Yeah. This is the skill that I was trying to demonstrate.
Mm.
I don't actually have a slide for it up because I wasn't sure I'd have time for it. But what I'm doing is the ask, offer, ask approach from motivational interviewing.
Mm-hmm.
So I'm asking you what your question is, and
Yeah.
then when you share your question, and then also asking like, what's really your concern about that?
Yeah.
And what have you heard about that already?
Yeah.
Then I've got more information about what are you really specifically wanting to know. I then offer a little bit of information. That's the offer. And then I ask again, what do you think of that? What do you make of that? What are you taking away from that? And then Allison, you're sharing it back, and then I can reinforce what you're taking home. It's a very quick, simple way. Thank you.
So there's lots of kudos for a thoroughly informative, great talk, which I agree. I really love that you spent a fair amount of time talking about women because it oftentimes it almost universally you ask women if they're having, if they ever have any, I used to say ever back door, and oh my God, I'm gonna do that. It's this very almost, I think, stigmatizing thing, and they're so used to people saying, well, you must be that kind of woman and what have you. So thank you for opening that up because I think that it's much clearly by the data much more common than women are often willing to acknowledge. And so, I mean, some of the questions we all are oftentimes talking about how to get, men to talk about it, but really, we really just need to be asking, women. So just would love to hear other ways, things that you oftentimes recommend in terms of getting people to be more open about that, besides what you already talked about.
Yes. So if you're a physician or a clinician, one of the things that the people in interviewing other providers, one of the things they recommend is simply just asking the question in the same way that you would ask about general health. Like you've got your list of questions that you ask, and you just ask, like, do you engage in any anal, it's hard to say actually, it's like saying the rural juror. Do you engage in any anal play? Or do you have anal sex? And asking in a very neutral way with the expectation that people may not actually disclose to you the first time. It may take a couple of times, but if they don't say it, you can ask again and say, I just ask people because not everyone feels comfortable being open about it the first time. And so I ask people, and also things can change over time. The other thing I'll say is I just have to reiterate, it's about the environment. So I used to volunteer at a place in San Francisco. It was like a health clinic for people who are marginally housed or homeless. And the HIV test counseling supervisor in his office had these incredible posters of all kinds of bodies, all skin tones, shapes and sizes too, sexualities, gender identities, just all over. And they were all erotic. And it just communicated, you can talk about sex here in a way that, like a poster that's got HIV meds doesn't, or a poster that's just about PrEP doesn't.
Yeah.
So I think there's something to be said for changing the physical environment and the visual cues.
Agree. I think now I'm going to say, about 1 in 3 women have had anal sex in the last 3 months. So 6 months, right? So just curious, is something you've evolved into and love to, and just open up the conversation. So I'm like, I like that stat. So I'm going to use that one.
Yeah.
Other questions for Bryan? I've never seen more penises or butts in a talk ever.
I'm just seeing if there are any questions here.
Yeah, I don't see any. This is really great. Someone said, "Are you coming to this other meeting?" I was like, "No, I'm learning about butts. I'm learning all about anuses, and I'm enjoying myself." No, I think it was very helpful to understand everything from the anatomy to the conversations to you threw in douching, you threw in medical stuff, you threw in non-medical stuff, terminology. I mean, it was really fantastically done, and I think felt very inclusive to everybody. Everybody has an anus. Well, most of us have anus, and can be used in whatever way. And so I think it actually was, and I love the way that you framed all of it, because I think if you can't start there and understand that, then you can't talk about prevention or anything like that. All right.
Thank you. I'm going to point out just a couple of other things while I've still got folks. So one is that this comes from that early work when I was at the bathhouses and then the Harm Reduction Coalition, and then studied it as part of my dissertation. And then part of my K-23 really was to study it in more detail. And then we submitted an R01 application, which is another 5-year grant to really look at, is this effective? Because in the K-23 study, the one that I just finished up, what we saw is that there was an increase in anal rectal STI screening and PrEP prescribing for the clinics that really had the whole package of this Peaches intervention. One clinic, it increased, another clinic, it decreased. So we want to understand why that is. But now, hopefully, we're going to get some funding. It got a first percentile score, which means it scored as well as it possibly could have.
Yeah.
So our hope is that we'll get funded and be able to look at this. This will be in the U.S. South and the Mississippi Delta in 8 clinics, implementing this whole package and then trying to understand what works and doesn't work about it. So there are more resources coming if we get that funding.
Bryan, Cynthia has a question I think would be important to ask. She's asking, she's heard that numbing agents aren't the best because if you can't feel it, you may not know you're experiencing pain or maybe tearing or what have you. So maybe you could talk a little bit about that.
Yes, I've got a slide about that too.
I had never heard about the anal condom actually. So I had not heard it.
Interesting, right? So anal ease is one of those numbing agents that's a topical agent that's used. It's meant to be used just on the anal canal, but people also sometimes put it a little bit further in. So the problem with this is that it's not FDA approved for that use, and we don't really know what's inside of it. So when something's not FDA approved, it means that whoever's producing it doesn't have to abide by strict guidelines of what actually goes inside of it. Think of it like a vitamin that's not, FDA approved. What's in it, you don't really know. The other thing is that they deaden sensitivity of nerves. So it's a little bit like, remember your palm of your hand, right? So if you have a numbing agent on the palm of your hand and then you're cutting something with a knife and you happen to come in contact with your skin, you may press harder than you realize and cause some damage. It's similar when it comes to anal sex. So anything that's reducing the ability of your body to sense something for the purpose of anal sex, it's blocking your ability to also communicate damage. It's blocking your sense of ouch. And the truth is you don't have to experience any pain during anal play. Really, your body will naturally respond as you learn your own particular stimulation, arousal stimulants, arousal stimulation cues is what I'm trying to say. So it's recommended that you don't use them for those reasons. We don't know what's exactly inside of them. And also, they deaden your ability, as Cynthia mentioned.
Awesome. All right. Thank you so much. Bryan, that was
Thank
really
you.
our pleasure. And Marina's is always saying we have to have you back to talk about anything. This is great. Thank you everybody for being interactive and your questions and your voting and the like. Marina's, anything to take us home? Anything you want to say to the crowd?
No, actually, the YouTube video will be posted tomorrow. And of course, we'll ask Bryan to share his slides and hopefully those links to the video so we can share those as well.
Awesome. All right.
Happy to.
Thank you, everybody. Take care.
All right. Take
Thank
care,
you.
everyone.
Bye-bye.
Bye.
Thanks again,
Thank you,
Yang,
Bryan.
for introducing your
Thank you.
enthusiasm.
Yes, thank you,
Yes,
Yang.
thank you, Yang.
All right. Bye, everybody.
All right.